we ask our guests to take their places in the meeting room. You will see that seats have already been assigned. For technical and organisational reasons, we ask you to kindly not move the place cards and to keep the same arrangement. Good. If you're all ready, we can begin.
Hello, colleagues. Just like you, I often come across specialists and family doctors. I'll get the ball rolling for this new interview on 10 milligram.
I can finally show you the equipment you have in front of you. It's known as PIU, which means Personal Interaction Unit.
When I ask you some questions, let me know what you would do in my situation, and I'll act according to the advice the majority of you choose.
Come in.
Thank you. Doctor.
How are you? Come
Fine.
on in and sit down.
Thank you.
I better know what you've come to talk to me about.
Thank you, Doctor. I'm pleased to see you've been waiting for me. So then, as I promised you, I'm here to show you the new 10, or rather the right dose. Well, we know that we've been preceded, but as I'm sure you'll agree, it changes very little. I think the subject deserves further discussion, given its importance.
Yes, I know you consider it to be important. So then, let's hear what you've got to say.
Okay, Doctor. Let's talk about the correct dosage for treating your patients in the high or very high risk bracket.
10, the correct dose, is a rather relative concept. In clinical practice, a medicine's dose is relative to the level of hypertension and the patient's clinical condition.
In this case, there's nothing relative. Let me explain why.
Of course. But you see, we can't base our dosage on what you tell us. I'm aware of the HOPE study. I've got nothing against 10 milligrams, but let's just say I prefer to start gradually, as many colleagues prefer to do the same. I prefer to initially impose a treatment of 5 milligrams of ramipril. Obviously, it's different if I'm dealing with a post-heart attack or decompensated patient, where it's advisable the maximum tolerated dosage of up to 10 milligrams.
I think that we'll find ourselves in this type of situation quite frequently. What should we do? I'll propose 2 alternatives.
Here's a list of options from which to choose. I see that none of you have expressed your choice. You're welcome. There's a significant majority, even though not unanimous.
All right. If you think that this cardiologist doesn't want to use 10 milligrams, even though he's understood there aren't any problems, how would you tackle the discussion to break down his reluctance? Which of these 2 questions would you ask him?
You can consult each other. Only 2 of you have not yet chosen. How did you choose? We'll look at it together.
Very good. Maybe, Doctor, your reluctance to actually use ramipril 10 milligrams is influenced by the fact that normally you use ACE inhibitors.
Well, I certainly don't just use ramipril.
Of course, Doctor, there's an enormous choice of ACE inhibitors. Lately, perindopril has presented 2 new studies. What do you think?
Actually, your colleagues at perindopril presented me with both the Progress study and the European study, and it seems as though they achieved good results.
If we want to be entirely truthful, in both study cases mentioned by you to obtain certain results, if I'm honest, a small stratagem was used. In the HOPE study... Here we are. Well, he should be in.
Come in.
May I?
Of course you may.
Good morning, Doctor.
Good morning to you.
As I promised, I'm here to show you something new. 10, the right dose. We know that we've been proceeded, but as I'm sure you'll agree, it changes very little. I think the subject deserves further discussion, given its importance.
Look, I really think you shouldn't be coming to an endocrinologist. You should be going to a cardiologist. Is an antihypertensive. Let cardiologists treat hypertension.
What would you say to this endocrinologist? Well then, Doctor, what are your worries or doubts?
As you know, the HOT study demonstrated that the target for optimal pressure in a diabetic patient should be even lower than a non-diabetic. Therefore, a diabetic patient is difficult to treat, because as a high-risk cardiovascular patient, very low pressure levels must be obtained.
I'm aware of the results of the HOT study, but that's why it's fundamental to adopt an appropriate pharmacological treatment.
Do you know why they carried out this type of evaluation? Wouldn't a measure of clinical criteria or pulmonary functionality have been sufficient?
To tell you the truth, I thought the same. But I don't know. Listen, I'll ask my colleagues. Do you know why? My colleagues tell me that, in their opinion, an evaluation of the clinical criteria would be sufficient.
You see, it's not the case.
Here we are. How many times have you heard this type of objection? Let's share our experiences. I'll propose a series of ways in which you can tackle this observation. Which do you prefer? It's true that it burns, but it's only a passing effect that you feel in the first few days. And I can assure you, Doctor, that even though there are patients who can't manage to keep it in their mouths, there are plenty who use it as if it were fresh water. Have you tried it, Doctor?
So you think I should insist on it, then?
I've got it. I realized my way of approaching this doctor was wrong. But I don't understand how I should have behaved. For example, should I stay near him or at a distance?
We'll look at it together.
Okay. Are part of our history, our tradition. And today, from this very tradition, I'll propose something that confirms the important use that these two molecules have had throughout the years. Years dedicated to bettering your oncological patient's quality of life.
Excuse me, where are you going?
Nowhere, I just thought I'd stand by your side so I can explain things even better.
I can understand, even if you're seated, you know. You don't need to stay right over there in the chair. You can come closer, actually. That's decidedly better. What do you think?
All right, Doctor.